basic academic materials, some basic academic materials and so on.
Hello, good afternoon from Washington, D.C., the U.S. nation's capital. My name is Dr. Rami Azuine. I am the lead faculty at the Global Health and Education Projects. On behalf of the Board of Directors and the faculty of the Public Health 360 program, I am so excited to welcome you today to the Summer 2024 Graduation Ceremony for our Public Health 360 Fellows. Today is always one of the most exciting days that we have in the organization. One of our missions is actually to ensure that we are training highly qualified next generation public health practitioners who will go on to save lives in the United States as well as across the world. Today, we are getting an inch closer to that mission as we are graduating 20 Public Health 360 faculty, 360 fellows from across the world. Over the last 3 months, these exceptional 20 fellows have undergone rigorous training, intensive hands-on programming, really difficult and challenging programming leading to their graduation today. We believe that with the intervention of our faculty, with their personal resilience and their hard work, they are really ready to become global health practitioners. And I am really excited that today we are going to hear from them. You know, they have designed 3 specific programs that will be used to address really emerging issues in the United States as well as across the world. So we are going to sit back today, listen to them, and hear how they plan to transform the world. I really want to thank all our alumni who are joining today, family members of our fellows themselves who have really worked so hard day and night to get to the programming that they would develop, and they are going to present today. So, we have the agenda here. I'm going to run through the agenda. I do not want to waste your time. I always want to make sure that you hear from our fellows because they have heard from me over the last really 3 months. So we are going to begin generally with an introduction of our faculty, and then we're going to get to it. You know, our fellows are going to introduce themselves according to the alphabetical order of their last name. So those whose names start with A are going to start, and those whose names are going to start with Z, we go along that side. So I'm just checking. Just a quick announcement that this program is being concurrently broadcast on YouTube. So Brown should be able to send in the link to the YouTube. If you have friends or colleagues who would rather join us through YouTube, they can do so as well. Right, okay. So I'm going to see who is available to introduce themselves. This is me. I am Rami Azuine. My story in public health is unique. You know, I was born in Nigeria. I have practiced public health, international development in Africa, in Europe, as well as in North America. I have practiced public health at the local level, at the national level, as well as the international level. And together with faculty, my next aspiration is actually to increase the number of minorities who are practicing public health, regardless of where they come from around the world. My background is in public health. I have both master's as well as doctoral degrees with nearly 20 years experience in public health. And that's me. Next, Brown, who do we have? All right, Dr. Susan. Introduce yourself, and then we take it Dr. Nzube, Dr. Chidubem, and then Brown, our tech guru. Okay, go ahead.
Thank you, Dr. Rami. Welcome, everyone. My name is Dr. Suzanne Ekejuba. Here at GHEP, I'm the program director. My backgrounds are in pharmacology, veterinary medicine, and data science. I came into public health from the back door, being that I work for one of the world highest public health agency. So everything public health resonates with me. Everything public health is around me, and I've been working in it. So thank you and welcome. That is it about me.
Thank you so much, Dr. Susan. And now we're going to Dr. Nzube. Go in, Dr. Chudubem.
Hello everyone. Hello everyone. My name is Chidubem Eboluche, and I'm a public health student at Morgan State University doing my doctorate there. I also work for GHEP as a program director, and also with the Center for Urban Health Disparity Research, working as a research associate. Thank you all.
Thank you, Chudubem. And the last but not the least, Mr. Brown.
Thank you, Dr. Romy. My name is Mr. Brown Magnus Olivers. I work as an IT and the outreach coordinator here at GHEP, and I'm excited to see you all. Thank you so much.
Thank you, Brown. I think Dr. Zubi is on her way, but Dr. Zubi need not an introduction. She is the gateway to the program. Most participants in the program will, at some point in time, interact with Dr. Nzube, who is our navigator as well as our educational outreach staff. All right, next. All right, this is all our PH360 fellows. So I know that some of them are not here today, but we're going to take the introduction. Please introduce yourself. Tell us where you are joining from so that we can see actually the time, what the time is there. So you can tell us where you're joining from and the local time where you are joining from. So we're going to start with Yewande.
Good afternoon, everyone. My name is Yewande Adekoya, and I'm joining in from Ontario, Canada. Currently, it's 12:07 EST.
Thank you, Yewande. Please, if you are not speaking at the point, could you kindly mute your phone? And the next is Arvind.
Hi everyone, my name is Arvind Ganeshram. I'm from Southern California, and it is about 9:10 here a.m.
9:10 in the morning. Next, we have Dr. Blessing Awe.
My name is Dr. Blessing Awe. I'm calling from Nigeria. It's actually 5:05 now p.m. Thank you.
Thank you, Blessing. Thanks for joining us. Next, we have Dr. Chakoya Williams. Chakoya.
Greetings, everyone. I am Chakoya Williams. I'm joining from Orlando, Florida, and it is currently 12:08 p.m. Eastern.
The Sunshine State. Next is Dr. Fadmatter Ba. Fadmatter. All right, going next is Evie Ego. On the way. Next, we have Jonah Jones. Jonah.
Hello, everyone. My name is Jonna Jones, and I'm calling in today from Huntsville, Alabama, and it is currently 11:09 a.m. Central Time.
Central Time, Alabama. Next is Kendra Hester.
Greetings, everyone. My name is Kendra Hester, and I am joining from Philadelphia. It is 12:09 p.m.
Eastern Time. Next, we have Leah Thomas. Leah.
Hello, everyone. My name is Leah Thomas. I am calling in from Seattle, Washington, and currently it is 9:09 a.m. Pacific Time.
U.S. Pacific Time. Next, we have Megan Baker.
Hi, everyone. My name is Megan Baker, and I'm calling in from Texas. And currently it is 11:10 a.m.
The Lone Star State in the United States. Next, Dr. Michael Frempong. Next, Nathaniel McGugan. Nathaniel.
Greetings, everyone. My name is Nathaniel McGuigan. I'm based in San Francisco, California, and it is currently 9:10 a.m. Standard Pacific Time.
The great state of California. Next is Noon Ibrahim.
Greeting everyone. My name is Noon Ibrahim. I am joining from Egypt. Currently, it's 7:15 p.m.
Thank you, Noon, for joining from Egypt, Cairo, Egypt. Okay, moving on. Next, we have Sabrina Mansour. Sabrina. Okay, Sabrina is joining us from Bangladesh, Dhaka in Bangladesh. All right, moving on. The next is Saran Haptamichael. Saran.
Hi, everyone. My name is Saren Haptamichael. I'm joining from Ethiopia. It's currently 7:11 p.m. Having some technical issues, so I might not be on video today. Thank you.
Sending you greetings to Addis Ababa. The next we have Satya Singh, Dr. Tabi.
Hello, I'm Satya Singh and I'm joining from Australia, and right now it is 2:11 a.m. in Sunday morning. Thank you.
Satya, you deserve our accolade. 2 a.m. in the morning. Oh my God. Okay, next we have Shreya Suresh. Shreya.
Hello, everyone. My name is Shreya Suresh. I'm calling in from Pennsylvania, where it's now 12:12 p.m.
Fantastic. Thanks, Shreya. Next, we have Dr. Tanya Judd Barnes. Dr. Tanya.
Good afternoon, everyone. My name is Dr. Tanya Judd Barnes. I am calling in from Maryland, and the current time is 12:12 p.m.
Maryland, Washington, D.C. Next, we have Dr. Uchenna Ekenweke. Dr. Uchenna.
Hello, everyone. My name is Dr. Uchenna Ekenweke. I'm calling from Cardiff, Wales, United Kingdom, and the time is 5:12 p.m.
Wales in Aberystwyth. Nice, cool. Okay, that's all our fellows. Here we are excited. You can see diverse backgrounds, diverse locations across the world, different time zones. You never see people who wake up 2 a.m. in the morning to join programs unless they really want to change the world. So I am really excited. Join me and let us give a virtual hand of applause to our graduating fellows. Good. Okay, next slide, please, Brown. And this is the team. If you want to get in touch with us, please feel free to get in touch with any of them. And, our email addresses are here. Our contact information is here. And the website is myghep.org. If you land there, you're going to see our email. And please feel free to reach out to me, to Susan, to Dr. Zubi, to Chidubem, or to Brown. We are always happy to hear from you and to give you the opportunity to learn about the Public Health 360 program, or actually to learn about GHEP in total. Thank you. Next slide. Next slide. Fantastic. Okay, so Sabrina is joining us. So the time in Bangladesh is 10:08. I think if you're following what is happening around the world, it's really tricky right now in Bangladesh. But despite all those challenges, Sabrina has been here virtually every session of the program. And we just want to send her our greetings, our applause, and words of encouragement. All right, so did we miss anybody during the introduction? Raise your hand if we missed you. Who did we miss?
Dr. Michael.
All right. Dr. Michael Frempong, come
Hi.
on, give us an introduction.
Yeah. So my name is Michael Nketia Frempong, and I'm calling from Accra, Ghana today. It's currently 4:15 p.m. GMT.
Thank you so much, Dr. Michael. So Michael says from Accra, Ghana today. So during these 3 months, Michael has traversed between UK and Ghana. And for each of those sessions, he was present. Congratulations, you deserve this graduation.
Thank you.
Who else did we miss? I think we missed Dr. Fatma Daba.
Yes, thank you, Dr. Zome. My name is Fatma Daba. I'm joining from London, United Kingdom, and the time is 5:15 p.m. right now. Thank you.
Thank you so much, Dr. Fatma. Who else am I missing? I'm looking, just trying to make sure I see everybody. We agree that today, the only person that has an exception not to be on camera is actually Sabrina. So kindly be on camera, right? I see here a lot of, a number of alumni that I recognize their names. Thank you so much for joining us. You know, I can't name all of them, but I can see Kayode here. Kayode is our doctor-to-be. Thank you for joining. I see Nafal, I see Tori, I see several other individuals. Let me see. I see iPhone, Lee Patterson, you know, Yumlek, Demi, Kenechi, Mrs. Hester, Heber, Ishabari. Thank you so much for joining. You know, from your names, I think these are your family members. I can tell you, having been with them, I can tell you that over the last 3 months, your support of them, your encouragement of them, your bearing with them if they woke up in the middle of the night to turn on the work is really, really appreciated. I want to congratulate them. You know, as the person who leads this program, I can tell you this program is not for the faint of heart. They can tell you that. So without wasting your time, you know, I don't like wasting your time. We're going to go to the main deal of the day. So these fellows have been grouped into 3 groups, group 1, 2, and 3. And each of the groups had been given a public health challenge. So we had presented a problem, a public health problem to them, and we asked them to design a program that they will implement to solve those problems. So today you will be hearing their solutions to really, you know, intractable needs that we have around the world. The 3 groups are going to be presenting. One is going to be presenting a program to be implemented in Prince George's County in the state of Maryland in the United States. And then another group is going to be presenting on addressing diabetes, type 2 diabetes mellitus in Kenya. And then another group is going to be talking about mental health, i.e. addressing bullying among adolescents in Ghana. So you can see that there is an international representation, right? One program addressing an issue in the United States, another program, 2 programs in actually Africa, one in the western part of Africa, and then another one in the eastern part of Africa. Hopefully, next cohort, we can have groups addressing problems in Asia, addressing problems in South America, you know, addressing programs in other areas. That's why we need students from those areas so that they can advocate for their communities and for their countries. But I cannot wait to hear about the solutions that they are proposing. So as they are presenting, please feel free to use the chat to ask questions, you know, and after their presentations, we'll have opportunity to ask them any and all questions about their program. So please get ready to ask your questions. You know, we're going to see who is going to really have the most impeccable, innovative design to address a public health issue. So I'm not going to waste the time. Brown, please let us hand the virtual podium over to group number 1.
Hello, everyone. My name is Leah. This is
Hey,
group
Leah.
1.
Sorry, before you start, just hit view and present presentation.
Okay, is that good?
Yeah, that's good.
Okay. My name is Leah. This is Group 1 presentation on Eat Right Initiative, a program to introduce food insecurity in Prince George's County, Maryland. And the next slide here, introduce our team members. My name is Leah Thomas. I'm the project director of the program, calling in from Seattle, Washington.
My name is Arvind Ganeshram. I'm the Director of Monitoring and Evaluation. I'm calling in from Southern California.
My name is Jonna Jones, and I am the Director of Strategic Partnerships, and I'm calling in from Alabama, USA.
My name is Blessing Aware. I'm the Director of Technology and Platform Development. I'm calling in from Lagos, Nigeria.
My name is Shreya Suresh. I'm the clinical director and I'm calling in from Pennsylvania.
My name is Satya Singh. I'm calling from Australia, and I'm an assistant project director for this project. Thank you.
And my name is Michael Frimpong. I'm the Director of Outreach and Communication. I'm calling from Accra, Ghana today.
Thank you. Today we're going to be looking at Prince George's County background. We know that Prince George's County is located in Maryland, USA, and it has a unique mixture of urban, rural, and suburban communities. It has a total population of 946,971 people, with a median household income of $94,441. The three largest ethnic groups in the county are the Black or African American, about 60.4%, that's the highest. Then the Hispanic or the Latinos, about 20%, and the whites, that's the non-Hispanic, 11.6%. And then we have a few of the Asians and the Alaskan natives. Next slide. Then our problem statements. Food insecurity disproportionately affects more than 1 in 10 children with low socioeconomic status in the state of Maryland, according to the Hunger Free America 2021. In 2022, 20.5% of children residing in Prince George's County faced food insecurity, which is a very large percentage, 20.5%. It's higher than the state proportion of about 16.4% and the national average of 18.5% of the United States. Food insecurity leads to poor academic performance and health issues and development generally. Next slide. Our scope for the Eat Right initiative covers the proportion of children suffering from food insecurity in the county is also higher than any state in the Middle Atlantic region that we talked about, 20.5%. We're going to be comparing that with the states that are close by. We're going to be looking at Prince George's County and other states that are nearby, like New Jersey, with a percentage of 13.2%, Pennsylvania, 16.6%, Delaware, 18.1%, and New York, 18.8%. I'll be handing over at this point to Leah.
Thank you, Blessing. Program goal and aim. So our program goal of Eat Right initiative is to reduce the prevalence of food insecurity among children and families in the county. And program aim is to improve the nutritional knowledge among these families with children and provide these families with more cost-effective resources to promote healthier eating habits. So the objectives are A, by August 31st, 2025, families with children between the ages of 5 through 18 show a 70% improvement in nutritional knowledge through the post-test. And objective B is by August 31st, 2025, these families enrolled into this program can identify and seek participation in at least 3 cost-effective resources in the community to promote healthier eating habits and have reported using one of those resources in the past 3 months. And the next slide here, I hand over to Satya. Thank you.
Hello. ERI leverages the socio-ecological model to combat food insecurity in Prince George County. This model offers a comprehensive framework emphasizing multi-level partnership and collaboration across various sectors to support sustainable change. Starting at the society level, ERI collaborates with government agency and advocacy groups to influence policies that enhance food security through expanded food assistance programs. At the community level, partnerships with food banks and farmers market aims to ensure access to nutritious foods and foster community events that raise awareness about available food resources. On the interpersonal level, ERI will partner with the schools and faith-based organizations to create networks that encourage and reinforce healthy eating habits within families. Finally, on the individual level, ERI will provide families with targeted nutritional education and workshops promoting affordable and healthier food choices. By addressing food insecurity at these levels, the ERI program will foster sustainable change and long-term food security. The next slide. Using the evidence-based practice framework, PICOT, the implementation plan we have here as a population of 250 families with children aged 5 to 18, which is eligible for SNAP program, and which is a supplemental nutritional assistance programs, and it has its inclusion and exclusion criteria. And intervention is based on the nutrition education and workshops, direct relief initiatives, sustainability initiatives, and the comparator, it has we have families with children eligible for SNAP who are not enrolled at the ERI program, and the expected outcome is to increase access to affordable food and to increase awareness of resources within the community, and the timeline we have is for 1 year. Thank you so much, and I'm handing over to the next colleague.
Thank you, Satya. The ERI will be working to facilitate partnerships with 3 local organizations, with the first being the College Park Community Food Bank. So this food bank was established in 2008 as a ministry through the College Park Church of the Nazarene, and it still currently works today as a food pantry warehouse. And outside of the warehouse, it has developed initiatives like the 15 Ways to Reduce Hunger, seedlings distribution, and local farm partners and gleaming to address food insecurities. With the College Food Bank's expertise, we hope to use them to organize food drives and connect with other community organizations to host them. Next, we have the University of Maryland Community Learning Garden, which was first started as a graduate students project, but quickly turned into a group venture for students, faculty, and staff. So not only does the community garden educate the community on ways to create functional green space, but it works to bridge the gap between education on nature and food, along with educating the community on community health and providing them with healthier eating habits. With the UMD Garden, we hope to educate participants on sustainable agriculture and provide them with the tools to go out and start their own community gardens. Next slide, please. And lastly, we have the Prince George's the Prince George's County Food Equity Council, which is a task force that was first established to support healthy living by working to create policies, work groups, and initiatives to create food equity in the county. One of their programs, the Food Rescue Program, works to provide food pantries and faith-based organizations with quality food donations that would otherwise fill landfills. And lastly, and more importantly, they also work with local grocery stores and farmers markets to provide them with infrastructure and support to thrive in the community. And with this partnership, we hope to connect with all the local grocery stores and farmers markets so that we can find stakeholders to participate in our voucher program. I'll now be handing over the slides to Shreya.
Thanks, Jana. So diving a little deeper into those partnerships, in order to get the word out about the Eat Right initiative, we'll be tapping into the strong social media presence of our partnership organizations. So the College Park Community Food Bank has 2.2K Facebook followers, as well as a location tag on Instagram. So creating posts to publicize ERI on their social media platforms will help draw folks to the program. They also have a reliable community of volunteers who could help with flyer distribution and getting the word out to their family members or friends who may be eligible for ERI. Furthermore, this organization has an established program that organizes food drives in PGC. So ERI will use these resources to raise awareness about program-specific food drives and get as many community members involved as possible. The UMD Community Learning Garden has 1.2K Facebook followers and 1.6K Instagram followers. Similar to the previous partner organization, collaborating with them to share ERI information on their social media platforms will reach those who already have an interest in community gardening and may be part of ERI's target population. Additionally, we will be partnering with this organization to host our community garden educational sessions to inform community members about the techniques required to grow one's own produce. This partnership will contribute to the sustainability of ERI's impact to reduce food insecurity in PGC, as community gardening promotes long-term involvement of participants beyond the one-year scope of this program. And finally, the PGC Food Equity Council has 1.9K Facebook followers and 1.75K Instagram followers. Similar to the other two partnerships, ERI will use FEC's social media presence to publicize the program's various offerings. Furthermore, the FEC's community network will be useful to disseminate ERI's promotional flyers and educational materials. This organization runs food collection and voucher programs with people who may be eligible for ERI, which would be an effective way to recruit participants from our target population. In order to do ERI-specific recruitment from our target population, we will be having ERI-specific social media platforms, including Instagram, Facebook, YouTube, and TikTok. And like I mentioned, we'll be collaborating with our partner organizations on these platforms. We will also be distributing advertisement flyers detailing all of the different offerings of ERI. And in order to make our educational offerings accessible to those who may have time conflicts, and things like that, we will also be disseminating videos and pamphlets with education about nutrition and community gardening. And we will be tapping into government boards that may be able to support ERI in PGC. I will now pass it on to Arvind.
So I just want to go over a little bit about the project activities and the description. This is a two-part project. The first part, as Shreya and Jana were mentioning, are the food drives and direct relief initiatives. Those include where we partner with faith-based organizations and some of the other organizations that Jana mentioned to organize community food drives and distribute vouchers to make the cost of fresh produce cheaper. The second part of this is a community garden aspect, and this is where we hope that we will improve the sustainability of our program. There are multiple grants available for new and existing community partnerships in the thousands of dollars. So hopefully with advocacy, we can achieve those grants. And additionally, like Jonah was mentioning, some of the gardening workshops to mentor and educate participants about creating new ones or working in existing community gardens can be very helpful long-term. The final aspect of this program is nutritional education and resource assistance. So this will include educational classes covering a variety of nutritional topics, meal planning, cooking on a budget, healthy eating, as well as assistance in enrolling participants in nutritional assistance programs offered elsewhere, like through the government, like SNAP or other programs that are available. Next slide, please. And this is a logic model. This is a brief overview of everything that we're going to be doing. So as I mentioned on the left, on that input side are those nutritional classes, family food vouchers, community gardening workshops, and food drives that we're going to be doing. We anticipate that we will have 2-hour classes held twice a month for 6 months, and this will be in the second phase of our project. Additionally, we think that the voucher for these 250 families will be about $50. We will also have 2-hour classes held twice a month with gardening experts, and the food drive that we will organize will be in the third and fourth quarter. And we have mentioned that our short-term goal is to improve the nutritional test, and we'll talk more about the nutritional test on the next slide, by 70%. And also, we hope that participants at the end of the program can identify 3 cost-effective resources and share that they have used one, importantly, in the past 3 months. And we believe that this long-term will help us in our goal of reducing food insecurity among the participants, and also that this program will be sustainable going forward. Next slide, please. So this is how we're going to measure how we do our program. And the first part is the questionnaire to recruit participants. There is a USDA House Food Security survey model. And this is a 18-question scale, which is used to assess food insecurity. This will be one of the things that we use to recruit participants. The additional thing to recruit or to think about how effective our program is a pre and a post test. So before a participant joins, we will give them a nutritional pre-test. The same nutritional post-test will be given at the end of each educational session, and that's to ensure that people are paying attention and that our educational sessions were effective. This will be repeated at the end of the study to see if those lessons stayed. The other thing is a food insecurity questionnaire, which is similar to the initial questionnaire, but this will be given periodically to assess if our program is improving the food insecurity of our participants. And the final thing is an activity log. This is a way of tracking participation. This is participants signing in for each session they attend. This is just so we can keep track of who's in the program as we go along. And I will pass it on to Michael next.
Thank you so much, Arvin. With regards to staffing, we will be adapting what is like a hybrid of a functional and divisional organizational structure. So which will be spearheaded by the two project directors. So on one wing, we'll have the key program activities as my colleagues have gone through. And we have leadership for each of the three activities we'll be holding. And the community garden project will be led by our Director of Strategic Partnerships. The food drive program or activity will be led by the Director of Outreach and Communication. And the nutritional bit will be done by the nutritional educators and resource aides. For a program of this magnitude, it's imperative that we pay good attention to data and technology. Hence, on the other wing, we have roles to facilitate monitoring and evaluation, and also technology and external support. Next slide. So like I said, for the three key activities, number one, the food drives, we'll have the Director of Outreach who will lead that activity. So they will coordinate the community hubs for food drives, and he will also spearhead the outreach and ensure collaboration with local farmers for produce vouchers. For the second activity, which is the community gardening, it will be led by the Director of Strategic Partnerships, who will help us oversee partnerships for mini grants programs, collaborate with local organizations to expand community gardens, and ensure workshops are supported by community mentors. And our nutritional educators will also develop educational materials for healthy eating, meal planning, and SNAP assistance as well. They'll help us with that. So like I said, on the other wing, we have the program support functions, where our Director of Monitoring and Evaluation will be helping us, and he'll be responsible for tracking the program's impact and also monitoring the progress and ensuring the effective use of data. And also when it comes to the use of technology in this program, we have our Director of Technology and Platforms who will be helping us with that. And then we also have the external support and partnership coordinators who will be helping us with providing expert advice on food policies affecting the community, which is Prince George's County. Next slide. In terms of our project timeline, we've divided it into two phases. So we are projecting the whole program will be implemented within a space of 12 months. And we've divided that 12 months into 4 quarters. So for the first 2 quarters, that's the first and second quarter, we'll be doing assessment and planning. And for the third and fourth quarter, we'll have our implementation and the evaluation phase. So for the activities, we plan on finalizing our materials and supplies. And for the first and second quarter, since marketing and campaign is really, really important for a program like this, we are allocating the first quarter and the second quarter to handle that. And we look to distribute the vouchers in the third and fourth quarter. And for the education and workshop, we'll purchase our supplies and technology within the first and second quarter. And for the third and fourth, we will hold our education and workshops. Yeah. And for external partnerships and for the survey, for the first and second quarter, we plan on hiring external staff members, also facilitate stakeholder engagement and partnerships. And also by the second quarter, we'll be majoring on the pre-survey for the external partnerships and enroll participants. For the third and fourth quarter, we'll be looking to have our food drive activity in full motion. And by the fourth quarter, we should have our post-survey. In terms of evaluation and reports, yes, we will do that on the third and fourth quarter. So there'll be a quarterly program evaluation and also data analysis and final reports done on the fourth quarter. I will hand over now to Leah to take it from there.
So this slide shows our budget for the proposal. So the total grant request is $420,000, and our estimated total cost for the program kind of corresponds with that total budget or the ask for the program, the request for the grant. So when you look at the budget, the figures, our primary cost comes from, or the expenses comes from the staffing salaries for both internal staffs and for the external nutrition education staff and for the workshop staff. And the next tier of expense is mostly for acquiring community garden extension grants and also for distributing vouchers, as the total cost of vouchers comes to $12,500. And the other items listed here comes in our cost, our communication for outreach like marketing and program supply materials for education and workshops, technology for purchasing laptops and other softwares for data analysis, and transportation for our travel expenses and food drive arrangements. And as a miscellaneous cost, we have set aside 10% of the total cost to cover any overhead expenses. And the next slide here is our conclusion. So in conclusion, we want to emphasize the problem of the community, of the county that's facing, and how it's impacting the little children, and why interventions like ERI is important to help reduce prevalence of food security among children and families in the county. And next slide is references. And thank you.
Very good, very good. Group 1. Please use your reaction buttons and let us show some love to group number 1. Let us show them some love. Show them, use the reaction button. Show them some love. I'm going to show them a tada confetti. I want to see the love you're going to show them. Yes, I'm seeing it. Show group 1 some love. Folks, this is amazing. Great programming. Eat Right initiative. So if it focuses on providing resources to address food insecurity in Prince George's County. Okay, questions are coming. So one question someone sent me directly is, what are some of the challenges that you have identified in implementing this program? Who wants to take that? Leah, you and your team, what are some of the challenges?
So I would say one of the challenge is primarily is lack of awareness and lack of understanding of the nutrition part, and also not having enough understanding of the resources available in the community. And that's what we are hoping with that nutritional education and awareness aspect, to bring that to the family members, that there are resources in the community that they can reach out for easy food access and, change their eating habits into healthier eating habits.
Any other thing to add, group 1? When you plan to implement this program, what are some of the obstacles you envision that you can anticipate that will make this program not to run as planned, or to make this program not to yield the outcome that you have planned? or to actually even not even implement this program at all? What are some of the challenges that you really identified?
I think one of the challenges that we'll face is that some people will be too ashamed to come out and actually be a part of it because they'll feel that this is actually for the low income people. Even though they don't have, they might think, people will think I don't have, so let me just hide. But I think with everything we have on ground, it will make it so easy for people to be a part of it, and we'll come out to make it very friendly, and they will want to be a part of what we have. Thank you.
Good. I have another question here, actually, very important question. Listen to this, I'm going to read. Do you know what, group one, do you know why median income in Prince George's County is high at $94,000, but food insecurity among children and families are higher in the county than the whole state of Maryland? For example, in Baltimore City, median income is $55,000. This is for you, group one, not me. Don't look at me, that's for you. Why do you, this is an affluent county. This is not a poor county. So why do we have nearly 21% of food insecurity in the county among families, whereas counties like Baltimore County, that is not even half as rich as Prince George's County, does not have that much?
It's indicative of the amount of disparity that's present in the county, and it's just another reason why we need to, we need programs like this that address those things. And it also shows that there are resources in the county that can be of use, and that these types of things can be effective.
Any other thing? Right. So the idea that you are trying to present there, Arvin, is that even within the context of affluence, you can still see, perverse poverty within the concept of affluence, right? So in such a county, and this person who asked this question really raised important points. For example, you have a wealthy county, yet you have poverty in the midst of that wealth. And it's important. That's one of the things we teach in Public Health 360. We say that you are going to become health disparity experts, right? Smart E. Yeah. Everything you are doing, you must ensure that equity is a key component. And then the person is putting this, maybe part of these reasons is because of the location, suburban versus the city. Those who live in the suburban areas might be a little bit more affluent than those who live in the city, and so on. And these are some of the issues we see in California too. California has almost like a country's economy, but there are pockets of places you go to in California, and the poverty is unbelievable, which means, and which indicates that the drive to address and eliminate health disparities must continue, regardless of where we find ourselves, whether we live in developing countries or whether we live in developed countries. Good work. Does anybody have any questions? Please, you can use your raise hand button and we will unmute you and have you ask your questions. Any questions from the other groups? All right, congratulations. Thank you, group number one. Moving on now, if you can stop sharing, we're gonna move on now to team number two. Team number two, take it away.
Good day. Good day, ladies and gentlemen, esteemed guests, and fellow advocates for community health. We are going to address another pressing issue, the escalating rates of diabetes in our community. In this context, we introduced diabetes awareness program in Kenya, DAPK, a crucial initiatives we are honored to discuss. I hope you find this presentation informative and insightful. The next slide, please. The DAPK team will introduce themselves. I'm Fatma Dabo, Lead Project Director. I'm joining from London, United Kingdom.
I'm Nathaniel Bigwigan, Director of Monitoring and Evaluation, based in California in the United States.
We have Jay Single, Director of Community Outreach and Communication.
Hi, I'm Dr. Tanya Jett Barnes, located in Maryland, and I'm the Clinical Director.
And we have Sabrina Mason, Director of Technology.
Hello, everyone. My name is Saren Habtemichael, the Director of Strategic Partnership, joining from Addis Ababa, Ethiopia.
Next slide, please. Next slide, please. DAPK adopts a comprehensive approach to address the multifaceted challenges of diabetes by raising awareness, providing early detection initiatives, establishing support groups, and leveraging engagement. Our program aims to empower individuals and community to make informed decisions about their health. One of the key aspects of the DAPK program is the focus on lifestyle changes, such as promoting healthy eating habits and regular physical exercise, which are crucial in preventing diabetes. Further implementation of evidence-based strategies and the SMART model, our objectives are clear and measurable, but also realistic, equitable, and time-bound to ensure the success of our mission. Next slide, please. DAPK's primary goal is to decrease the incidence of type 2 diabetes cases among adults aged 18 to 64 in Nairobi, Kisumu, and Mombasa by 15% within 2 years. Our program will employ a comprehensive approach incorporating evidence-based intervention to achieve this. This intervention will center around lifestyle modifications, nutritional education, and physical activity program tailored to Kenyan context. I will now hand the floor over to Dr. Tanya Jett Barnes.
Thank you, Dr. Padmata. Diabetes is one of the top 10 causes of deaths, and it has steadily been rising since 2000. In Kenya, non-communicable diseases are estimated to account for 27% of all deaths, with diabetes being responsible for 10,000 deaths. In 2021, the International Diabetes Federation reported Kenyan diabetes-related mortality at approximately 15,284 persons in ages between 20 to 79. In 2013, the adjusted prevalence of diabetes in Kenyan adults was estimated at 3.6%, which is projected to rise to 4.4% by 2035. In 2020, 74% of all global deaths, or 41 million annual deaths, were attributed to non-communicable diseases, of which 2 million resulted from diabetes or its complication. By 2040, low-income countries will have 92% increase in mortality due to diabetes. Undiagnosed diabetes poses a public health concern with costly public health implications, especially in Africa. Next slide. The primary cause of the increased rates in diabetes cases in Kenya are changes in lifestyle, adoption of unhealthy diets, lack of physical activity, and demographic and social changes among aging population, globalization, and urbanization. Diabetes is among the leading causes of renal failure, limb amputation, blindness, and major triggers of cardiovascular disease, which is the leading cause of death in diabetes. The complications of undetected, untreated, and unmanaged diabetes is a serious human suffering and causes disability. Stepwise survey of 2015 showed that there were more than 88% of Kenyans had never had their blood sugar checked, which resulted in late diagnosis and increased risk of mortality and morbidity. Next slide. This is a chart taken from the World Health Organization in 2016, showing the mortality of diabetes in Kenya out of a population at that time of 46,050,000. In the lower to middle income groups, there were more male deaths in ages 30 to 69 than women, more women deaths in ages over 70 compared to women 60 and younger. Interestingly, the number of deaths in men were higher than women related to high glucose or undiagnosed diabetes cases, but the same in older ages 70 and above. Next slide. This is a pie chart also taken from the World Health Organization showing diabetes attributed to 1% of the non-communicable diseases and deaths. The prevalence of the diabetes were associated with having certain risk factors, one being diabetes, overweight, obesity, and lack of physical exercise. Females shared the largest proportion of mortality in all three risk factors. Next slide. DAPK, Diabetes Awareness Program in Kenya, has 3 objectives. The first objective is to increase awareness of type 2 diabetes among Kenyans through education. The second is to promote healthy lifestyle by increasing healthy food options, especially urbanized and in aging populations. And third is to develop an exercise program targeting those older communities and those in urbanized settings. Next, I'll hand over to Saran.
Thank you, Dr. Tanya. Now that we've looked at our objectives, we're going to see how we are able to implement our objective. Our first objective, which was to increase awareness about type 2 diabetes, which is a condition that is on the rise in Kenya due to factors such as urbanization, sedentary lifestyle, and changing dietary habits. We're considering to implement strategies such as community outreach. We will be conducting educational seminars and workshops in various large cities such as Nairobi, Kisumu, and Mombasa, providing information about diabetes prevention and management. Secondly, we will distribute informative materials which are culturally appropriate, such as brochures, pamphlet, and poster. These brochures and pamphlets will explain the causes, symptoms, and risk factors for type 2 diabetes. Third, we will implement partnership with healthcare providers. These healthcare professionals will help us integrate diabetes education into their services and will help us reach a wider audience. Fourth, we have media campaigns. We will be utilizing radio, television, social media to raise awareness and promote healthy lifestyle behaviors. Next slide, please. For our second objective, which is to promote healthy lifestyle among Kenyans, this is very essential because it will help us prevent and manage type 2 diabetes. To do this, we will do nutrition education workshops, which are culturally appropriate healthy food options. We will develop recipes, meal plans that align with the Kenyan dietary preference by emphasizing the importance of whole grains, fruits, vegetables, and lean proteins. Secondly, we will also do nutrition counseling workshop. We will offer personalized nutrition advice and group workshops to educate individuals about healthy eating habits and, of course, portion control. Third, we will have community garden initiatives. We will encourage community-based gardening by promoting healthy food production and consumption. This will foster a sense of ownership and engagement in a healthy lifestyle practice. Next slide. For our community gardening initiative, we will partner with the Kenyan National Horticulture Association. This is a leading organization in Kenya promoting the development and sustainable agriculture. By partnering with the KNHA, our program, which is DAPK, will access their expertise in gardening practices, seed selection, agriculture extension services. We believe that this partnership will establish a very strong network of community gardeners across Kenya, which will directly promote healthy food production and consumption. Next slide, please. For our third objective, which is, next slide. Okay, thank you. For our third objective, which is to develop an exercise program, we will emphasize working with, we'll tailor for older communities and urban residents in Kenya. To do that, the strategies that we are considering to do is, first of all, we're going to do community-based exercise programs. As you can see on the picture, this is a traditional African dance such as bango, rumba, and bongo. We're going to incorporate popular, culturally relevant dances. These dances are not only enjoyable, but they will also provide a great way to improve cardiovascular health, balance, and coordination. The bonga drum, as you can see, a cultural icon in Kenya, can offer a blend of health benefits and cultural significance. We're also considering to partner with Ministry of Sports, Culture, and Heritage, dance centers in Kenya, the Sarkasi Dancers and Acrobats, which organize regular community events that will encourage physical activity, such as cycling, walking, and overall, this will promote a sense of support and community engagement. Next slide, please. For our theories of change, we believe in implementing the health belief model. DAP-K is grounded in the health belief model, which suggests that individuals' health behaviors are influenced by their perceived susceptibility, severity, benefits, barriers, cues to action, and self-efficacy. By addressing these factors, DAP-K aims to motivate individuals to adopt a healthier lifestyle. The other theory of change that we will be employing is the diffusion of innovation theory, also known as the DOI. This will help us accelerate the spread of healthy lifestyle practices among the Kenyan population. By targeting opinion leaders and early adopters, DAP-K aims to influence others to adopt new behaviors. Next slide, please. On a final note, we are also considering to use the logic model, which is an effective, clear framework for understanding the program's components and how they work together to achieve its goals. As you can see, we will be partnering with different entities. This logic model will outline the resources used, the actions taken, the results achieved, the changes in knowledge and behavior, and then for the impact, what the long-term impact on health and well-being will be. By understanding this model, DAP-K can effectively monitor and evaluate its progress towards reducing diabetes incidence and improving the quality of life in Kenya. Next, I'll hand over to my colleague, Nathaniel. Thank you.
Thank you, Sarang. Given the nature of this intervention, the DAPK will be executed in 5 phases over a 2-year period. The first phase, spanning the initial 3 months, will focus on planning. This will include the hiring of staff, development of outreach materials, budgeting, as well as fundraising. The second phase, taking place between months 4 to 6, will involve outreach and recruitment. We will launch an outreach strategy with a social media campaign, mass flyering in high traffic areas, and collaboration with local tribal chiefs to host barazas or local community meetings. Special attention will be given to areas within the densely populated informal settlements, where recruitment efforts will be intensified to reach those most at risk. This phase will conclude with a comprehensive screening period, which I will discuss in more detail later. The third phase, spanning months 7 to 18, will focus on program implementation and will feature nutritional workshops, physical activity sessions, and support groups. The fourth phase, taking place between months 19 and 21, will focus on the initial post-program evaluation and will be conducted immediately to measure the overall impact of the program. This assessment will incorporate a post-program survey, health assessment, focus groups, and one-on-one interviews. The final phase, covering the last 3 months, will be the follow-up evaluation and will evaluate the long-term impact and sustainability of the program. Insights from this evaluation will be used to develop a final report that offers actionable recommendations for future planning. Now that we've outlined the timeline of the program, let's transition to the next slide to look at the specific criteria we use to determine participant eligibility. Based on our inclusion criteria, we will recruit participants who are age 18 to 64, have been diagnosed with pre-diabetes. So this may include having an A1C level of 5.7 to 6.4%, a fasting plasma glucose level of 100 to 125 milligrams per deciliter, and a 2-hour plasma glucose level of 100 to 125 milligrams per deciliter. They must also exhibit risk factors for type 2 diabetes, which may include overweight or obese, a family history of diabetes, having a history of gestational diabetes, mellitus, or giving birth to a baby weighing over 9 pounds, and or a sedentary lifestyle. They must also express a willingness to participate, which means a commitment to attend regular sessions and engage in program activities, and they must be willing to sign an informed consent form to participate. Lastly, we have a maximum capacity of 120 participants to ensure that we can provide personalized care and maintain a high standard of quality throughout the program. Now I will pass it on to Sabrina, who will present via a recorded message.
Thanks, Nathaniel. The main expected outcome of our program is a significant reduction in the prevalence of type 2 diabetes among program participants. We will assess this by observing reduction in the incidence of type 2 diabetes. The DAPK program aims to reduce type 2 diabetes incidence by 15% among people aged 18 to 64 in Nairobi, Kisumu, and Mombasa, Kenya. The program will implement targeted lifestyle interventions such as dietary education, physical activity promotion, and regular health screenings to accomplish this. The incidence of new cases will be assessed at the end of the 2 years of evaluate program effectiveness. Then, improvement in dietary habits. Through nutrition counseling, cooking demonstrations, and healthy eating campaigns, the program will equip participants with the knowledge and skills to make sustainable dietary changes. By the end of 24 months, a 30% increase in diabetes prevention knowledge is anticipated among participants as measured by pre- and post-program surveys. Participants' dietary intake will be assessed at the program's inception, midpoint, and conclusion using surveys and dietary records. Then, increasing the participants' physical activity levels. To improve physical activity levels in these groups by 25% throughout the program will establish accessible and culturally relevant community-based exercise programs, as well as educational campaigns emphasizing the health benefits of exercise. Every 3 months, participants' physical activity levels will be measured with self-reported data and activity journals to evaluate the program's effectiveness. Nathaniel will explain more about the evaluation plan in the next slide.
Thank you, Sabrina. Throughout the program, we will employ a rigorous evidence-based approach to ensure the collection and analysis of high-quality data. As a part of the evaluation plan, we identified a series of instruments that will be used to track and record key performance indicators that will measure the program success in achieving its outcomes and highlight areas of improvement. Beginning with outreach and recruitment, we will utilize in-person outreach reports to track the number of flyers distributed, the number of conversations, and the number of quality conversations we have with community members. In the comprehensive screening period, a series of assessments will be employed not only to assess eligibility, but also to detect the morbidity rate of type 2 diabetes, the prevalence of risk factors, and participant eligibility ratio. During implementation, we will utilize key instruments such as attendance logs to track attendance rates. In the post-program assessment, instruments such as the post-program survey will provide a comprehensive analysis of the program's outcomes. We will examine We will examine key performance indicators such as participant satisfaction, behavioral adherence rates, and the rate of retention. In the final phase, the program will utilize the same instruments as the previous phase to evaluate the long-term impact and sustainability of the program, and will assess key performance indicators such as the incidence of type 2 diabetes and sustained behavioral adherence. As we move to the next slide, let's look at the quality improvement plan designed to uphold the highest standards of quality and integrity. This plan focuses on continuously improving the program's effectiveness through strategic planning, targeted changes, and ongoing monitoring. By regularly assessing our processes, we will ensure we meet the program's objectives and deliver a high-quality experience for our participants. To support this, we've integrated a three-tier survey system into our evaluation, allowing participants to opt in or out based on their comfort. This flexibility helps us to gather meaningful and real-time data to guide adjustments that enhance program quality and satisfaction. We break down the three-tier survey system in the next slide. In the first tier, participants will be provided with a paper-based survey distributed at the end of each workshop session. Participants who select the second tier will receive a call to complete a voice-based survey through an automated phone system. They will be prompted to respond to questions by pressing numbers on their keypad or giving a verbal response, which will be automatically recorded. If any issues arise with the information collected, a third tier, considered a sub-tier of tier 2, will be implemented. A post-telephone survey interview will be conducted by a trained interviewer who will probe for additional details to gain a deeper understanding of the participant's experience. Now that we've covered the evaluation plan, let's go into the next slide to discuss our staffing plan. We have several teams essential to the program, which includes the lead project director, who will oversee the overall management and strategic direction of the program. The clinical director will oversee the medical team, which will monitor the overall health of our participants. The director of community outreach will oversee community outreach initiatives and educational programming. The director of technology and platform development will oversee the IT tech support team and ensure that all technology is functioning smoothly. The director of monitoring and evaluation will oversee the evaluation team, which will be responsible for designing and implementing evaluation strategies to ensure the program's effectiveness. And lastly, the Director of Strategic Partnerships will develop strategies to identify and engage in cultivating partnerships with relevant organizations to support program goals. As we transition to the next slide, let's review our $120,000 budget, carefully plan to allocate resources effectively across each phase while remaining flexible to meet the unique needs of our community. Let's break it down. First, we have personnel costs, which account for approximately $76,000. This includes salaries, benefits, and capacity building initiatives to ensure our team is fully prepared to implement the program effectively. Next, we've allocated over $18,000 for administrative costs. This includes expenses such as office supplies, utilities, rent, and other expenses. Program promotion represents $550 for outreach materials. We've set aside close to $14,000 for consultants. This includes legal and social media consultants to ensure our program operates within all legal frameworks and optimizes its online presence. We have monitoring and evaluation, in which we allocated $6,300 to cover costs associated with data collection tools, software, and audio and video equipment to record sessions. Finally, we reserved $5,000 as a contingency fund to address any unexpected challenges or opportunities that may arise during the program. In addition to the grant that we are seeking, we will partner with grocery stores, farmers markets, and community leaders for in-kind contributions and additional funding. These collaborations will help maximize cost effectiveness and ensure the program's sustainability. Now I will pass it on to Fatimata to provide an overall summary.
Thank you, Nathaniel. While we prepared for anticipated barriers such as cultural resistance, limited resource, and low awareness, we recognize that overcoming these challenges will require the help of community members. The involvement of community leaders, health professionals, and organizational leaders is not just significant, it is crucial. We need the collaboration, partnership, and understanding of the communities to implement targeted strategies. Their involvement is the linchpin to the success and sustainability of our program. DAPK will draw a successful model from other diabetes prevention programs globally, adapting them to fit the local context. This includes implementing the diabetes prevention program frameworks, which have been proven effective in various settings. The program aims to ensure the effectiveness and sustainability by leveraging evidence-based strategy. In essence, DAPK is not just about addressing the rising incidence of diabetes. It's about fostering a healthy future for our community. The program is dedicated to leading the Kenyan community towards a healthy and more vibrant tomorrow through strategic partnerships, innovative activities, and evidence-based practices. In conclusion, the Diabetes Awareness Program, Kenya, DAPK, aims to combat the increasing incidence of diabetes in Kenya with a versatile approach tailored to the local context. The program will focus on raising awareness, promoting healthy lifestyles, and improving access to preventive care through educational campaign, community workshop, screening and early detection initiatives, lifestyle programs, and support groups. Partnership with local health authorities, non-governmental organizations, and educational institutions will drive the program's implementation and sustainability. Training for health workers and community leaders will strengthen the local capacity, while monitoring and evaluation mechanism will ensure program effectiveness and continuous improvement. Your contribution to this critical discussion are invaluable, and we look forward to working together to create a community where health and wellness strives. Thank you. We will now open the floor to questions and answers.
Thank you so much, Group 2. This is exciting. DAPK, Diabetes Awareness Program, Kenya. I do have a lot of questions, actually. But before we do that, let's use our reaction buttons and give Group 2, a resounding, let's show them some love, I'm going to use my reaction button, and then I'm going to give them some hearts. How about that? Great. Okay. So we have questions for you. So we're going to tee this up. I'm going to read the questions and then anybody in the group can take the questions. All right. So this person is making a comment. It says, are there cases in the past when diabetes prevalence was close to or equal to current state? Or is this mainly due to the social change affecting the nation of Kenya?
I think with the shift in demographic and globalization, we noticed that previously in Africa, there used to be more communicable diseases. But now we notice the diseases that used to be in the Western area world have moved shift to Africa due to globalization. Maybe the food we eat, lack of exercise, and our social activities that has contributed. So I would say recent changes and the shift in demographic and globalization has increased diabetes within the African region and particularly Kenya.
All right, second question. What challenges do you anticipate when working on a program that is going to be implemented across 3 major areas in the country? Nairobi, the capital, Kisumu, which is another one, and then Mombasa. What are some of the challenges that you anticipate?
And we mentioned some of those, like access to resources, cultural barriers, because within Africa, Kenya in particular, different regions have different cultures. And so cultural barrier would be one, and access to resources would be another, and even lack of knowledge and awareness of diabetes program would be another. And it is in that aspect that we believe that working in collaboration with community members will be very helpful and vital.
Okay, another question is about technology. So I'm hoping the Director of Technology and Platform Development will take this. The person was asking, you propose in your project that you will be using automated phone surveys. Is there a reason why you chose automated surveys?
Yeah, automated phone surveys would be a secondary resource for us. It's mainly for community members who are more tech savvy and are available to take a voice-based survey. Voice in the event that the participant is unable to take the paper-based survey for any reason. For example, they might forget on their way out the door to submit the survey, or they might not be interested at that time to submit the survey, or they may, for any other reason. The program is designed to automatically call a person if they sign up if they opt in to that choice. And so the automatic phone surveys are designed in a way to capture real-time data, and they're great in capturing everything that the person says in an interview.
Thank you. And then one final question is, can you discuss if you anticipate any conflict with having the clients use their phones to assess feedback?
We don't see any conflicts with that. They're at least 98% of adults in Kenya have a cell phone, and so it'll be easy to do the survey. But in terms of like ethical issues, we do mitigate that by utilizing secure database resources such as REDCap that will be secure in transmitting that data.
Thank you so much. What final question here is, what are you going to, you talked about diabetes monitoring. Are you going to issue diabetes glucometers to every participant? How do you want to do the diabetes measurement?
Yeah, so the diabetes measurement will be designed through the physical examinations. So like every 3 months, we will do physical health exam that will focus in on doing the blood tests as well as like other tests that will measure the blood glucose level of the participants. So hopefully we can capture some any issues in real time with any changes in their health.
Thank you so much. Group number 2, Diabetes Awareness Program, Kenya, DAP-K. And then I saw here we have criteria that each participant will need to go through before they can get the glucometers. Very good. Excellent. Okay, moving on now. Brown, can you stop on sharing? And then let us get, we saved the best for the last. Group number 3 is going to blow us away with another innovative program to address an incipient public health problem. Group number 3, take it away. And again, our audience, please keep the questions coming, keep the feedback coming. I really appreciate it. And remember, these projects are ready for funding. So you reach out to us and then we can give you the project team to go over there and implement the program. Group number 3, over to you.
Okay, greetings everyone. We are standing together for equity and peace, aka STEP, a program aimed to address bullying in schools in Ghana. My name is Kendra Hester. I am the Director of Strategic Partnerships, joining from Philadelphia, Pennsylvania. And now I'd like to introduce you to our team.
Greetings, everyone. I am Chakoya Williams. I am the Director of Operations, and I'm calling in from Orlando, Florida.
Ego EVA is our project director. She is located in Nigeria. She is not able to join us tonight.
Greeting everyone. I am Noon Ibrahim. I am the Clinical and Policy Director joining from Egypt.
Hello, everyone. I'm Uchenna Ekeweke. I'm calling in from Cardiff, Wales, United Kingdom.
Hello, everyone. My name is Yewande Adekoya. I'm the Director of Monitoring and Evaluation, and I'm joining in from Ontario, Canada.
Hello, everyone. My name is Megan Baker, and I'm the Director of Technology and Platforms Development, and I'm calling in from Texas, USA.
Thank you, Chakoya.
Thank you, Kendra. Ghana is a West African country that gained its foundation in March 6, 1957. It is the first sub-Saharan African country to gain its independence from colonial rule. Ghana, by definition, is known for its rich cultural traditions, including music, dance, and art. Ghana's lower middle income economy has a population of over 34 million residents. Of these 34 million residents, 56% of them are under the age of 25 years old. Amongst this population subset, bullying continues to be an ongoing problem that many face. Throughout this program, STEP would like to create initiatives that will take place in 3 metropolis cities in Ghana, which are Accra, Tema, and Kumasi. There are roughly 6.9 million adolescents in Ghana. Of those adolescents, there is a bullying prevalence of 41.3% between ages 10 and 24. Risk factors of bullying include age, social isolation, anxiety, suicide ideation, suicide attempts, current drug use, or having sustained an injury. Amongst these age groups, bullying is associated with poor academic performance and increased psychological distress, such as anxiety, depression, and stress. Adolescents are not always upfront about experiencing or participating in bullying. Here are some signs to look for when a child is being bullied or could be bullying others. A decline in grades, loss of interest in schoolwork, not wanting to attend school, avoidance of social situations, self-destructive or aggressive behaviors with peers, feeling helplessness, or a decrease in self-esteem. Various types of bullying include physical abuse, verbal abuse, harassment, cyberbullying, or social and sexual abuse. This diagram shows the connection between mental health treatment and various facility types that adolescents in Ghana receive mental health services. According to the graph, they present in outpatient facilities at 11%, which include hospitals, clinics, or urgent cares, and inpatient units at 5%, which include long-term care facilities or behavioral health facilities. And lastly, in mental health hospitals at 1%. Many children and adolescents face a need of alternative treatment and a way to streamline them to these facilities. STEP's aim is to do just that. Now I will be passing along to my colleague, Megan.
Thank you, Shakoya. I will now discuss the goals and objectives of the STEP program. So our primary goals are to reduce the negative impacts of bullying, and this will be measured by using the Depression, Anxiety, and Stress Scale, or DAS-21. And this is a validated questionnaire that assesses these 3 dimensions of mental health. For example, in the depression section, students might respond to statements like, I couldn't seem to experience any positive feelings at all. Or for anxiety, it might look like I experience trembling, such as in my hands. And for stress, a statement reads, I found myself getting agitated. So those are just a few examples of what might be what's in the question. And STEP's second goal is to increase the coping resources for students experiencing bullying. And this will be evaluated through the Olveus Bully and Victim Questionnaire. And this questionnaire clearly defines bullying and focuses on 3 key elements. So number 1, the intent to cause harm. Number 2, repetitive behavior. And number 3, a power imbalance between the victim and perpetrator. And in addition to these goals, the program has specific objectives, which are to increase awareness by 15%, improve comfortability in reporting by 20%, and increase access to anti-bullying resources by 10%. I will now hand it over to Yuande.
Thank you, Megan. And so our STOP program will be targeting school-age children within the age of 10 to 24. And we will be looking at 3 schools across 3 regions in Ghana. And the reason why we are focusing on this age group is because during this period is when behavioral formation takes place. It's also a critical time for development to occur. There's been a report of high incidence rates during this time, and the effects of bullying on mental health during this age could affect students' academic performance negatively. And so targeting this audience at this time, at this age range for this program will be very, very impactful. Also on their mental health and social skills as well. During this age, the impact of mental health and social skills of children in this range is very important, as this is when they develop their social skills. We also want to be able to prevent future occurrence that might arise from bullying, and so able to target younger children or young adults would make this program very impactful. Children are easily influenced as well, and then we're hoping that through this program, by introducing it into the school curriculum, peers are able to influence each other positively, which would, in the long run, bring about a positive impact. Family and community plays an important role in the life of children as they grow up, and so introducing this program to school-age children would help them to be able to extend this intervention, not only within the school, but even in the family sector and also in the community at large. Now I'll be walking you through the stages of the STEP program. Next slide, please. So the STEP program is going to be a 1-year program, which will be spanning through the period of the Ghanaian school system that starts from August to August. And the STEP program will be implemented in 3 stages. We have our planning stage, the implementation stage, as well as the evaluation stage. During the planning stage, we'll conduct outreach awareness program. This would be done to be able to raise awareness as to what our program is all about. We would also be during this stage, we would also be developing our program plan, and also bringing on board our staff that would be involved in this program. We would start with the initial training during this planning phase. And our implementation stage would involve the recruitment stage. This is the stage where we would enroll our participants and also conduct the initial screening, which would be using our DAS21 tool and also our OBVQR questionnaire for the initial assessment. Our intervention is going to be tiered, and then we'll be doing it in stages. We would also be going along with those Ghanaian school curriculum where they have the first term and the second term. So we would roll out our program plans in stages. And lastly, we would also continue with an ongoing training for our staff who would be implementing these programs. The last stage is the evaluation stage, and that is when we'll be measuring our outcome, our program outcome, to be able to see how effective the program is. We would continue to use our DAS21 and OBVQR questionnaire to measure the impact of our program. And lastly, we would also be conducting focus group meetings with school admin to be able to also measure their understanding of the program, and even afterwards to see how they can carry along with the program. Now I'll be handing over to Kendra. Thank you.
So our initial group training for our group leads will focus on creating a supportive and respectful environment. This training is adapted from Comprehensive Centers Network's 6 key ways school-based mental health professionals can help students. So you can read those 6 elements here. Students need integrated systems that advocate for them. They need to make sure that they can feel safe and to know that there are repercussions to bullying to help them thrive. They need systems that are collaborative and communicate. Now I'll talk to you about the ongoing group training. Our ongoing group leader training will occur monthly, and this is adapted from UNESCO's, which is a partner you'll hear about shortly. You can review these elements here. A whole education approach recognizes the importance of the interconnectedness of the school with the wider community. So this includes policy development around bullying, curriculum against bullying, that repercussions are open and available, collaboration with stakeholders to help create a safer environment, including families, all of which can impact bullying that occurs in school. STEP incorporates this through a robust, multi-tiered program. And this is supported not only through our training with our community partners, our group leads, but also the training that we do with our students. Next, we'll discuss the recruitment and enrollment. The 3 chosen cities have expanding economies and are only projected to grow further. Urbanization has more than doubled in Ghana from 23% in the 1960s to 51% in the 2010s. Urban areas have been shown to have higher rates of physical and sexual bullying or abuse. And these areas face unique challenges in an expanding economy. STEP will recruit 100 students per school. In Accra, the capital of Ghana, with a population of 2.27 million, STEP will look to recruit a school that has a high migrant to native ratio. Urbanization in Accra was nearly 88% in the 2000s, hence why we are focusing on the migrant population in this region. Tenma, part of the greater Accra region, and is considered a port city, is a small city with less than 300,000 people. And this city is often missing from recent literatures, although it is a major player for the Ghanaian economy. So we'll seek a school here that has the capacity to house our program. In Kumasi, which is the second largest city in Ghana, with a population of about 1.5 million, this city is in a transition phase and is located in central Ghana. It is considered a peri-urban or semi-urban area, meaning that it has rural and urban areas surrounding one another. So in this area, we'll be seeking a school who is in a transition phase, meaning it'll have both rural and urban resources. As mentioned, we're recruiting 100 students for each city. After students are enrolled, after they've taken the DASS or the OBVQR assessments, they'll be put into 2 groups, either the in-person or virtual group. So next week, we'll just discuss the methodology. So students in the in-person and virtual community spaces will have ongoing support. Those support will start once they have the first 1 week of education, where they'll learn about mindfulness strategies like yoga, meditation, dancing, and art therapy. Other coping tools they'll be able to use to combat negative emotions that can cause bullying or result from bullying. Additionally, at the beginning and end of each class, students will practice these mindfulness activities. In the beginning as a group, and at the end, solo. Next, we'll discuss the curricula that students will practice throughout the STEP program. This will occur also throughout the entire school term. So the Friendly School Systems is a whole school approach, and its aim is to promote social and emotional well-being among students. Some of the intended outcomes from the Friendly Schools curriculum is an improved school climate, decreased bullying and cyberbullying, increased sense of safety, increased help seeking, improvement in emotional self-regulation, and improvement in social problem solving. The praise curricula, titled Preventing Aggression in Schools Every Day, is focused on the students and led by the group lead. So this bullying program teaches problem solving, perspective taking, and how to be a positive bystander. So we aim to use this as a tool to help students improve in their ability to report or feel comfortable reporting. Additionally, praise seeks to improve the social problem solving, a reduction in hostile environments. Those students I've identified in the first and second term as having the highest percentage of need will be sent to the Adventures Abroad curricula. So this will happen within that middle period where students can have a personal series of scenes focusing on respect, thinking ahead, responsibility, communication, and friendships. So the Adventures Abroad program is a cost-based program, and its aim is to improve social relationships and emotional well-being among students. Due to the cost, we are only providing this to about 10% of each population in schools. Now we'll talk about the theory of change behind the STEP program. The STEP program will be grounded in the social cognitive theory. I'll be referring to this as SCT. So SCT shows the interplay between the student's environment, their actions and motivations on the individual's decision-making. This theory is being used to model the program because it can reach not only those who are victims of bullying, but also those who are perpetrators of bullying. The key constructs of SCT you can see are bolded here. So the STEP program will use the constructs of reciprocal determination and observational learning to show the influence of anti-bullying behavior can have on students. Policies in schools that promote no or zero tolerance, promote a safe and respectful environment, are essential to STEP to increase markers of social norms. Access in schools and virtually to alternative reporting measures, and support for referrals to mental health services. STEP will also educate through our materials that we provide to students on a weekly basis. Those are outcomes, expectations. And for our behavioral factors, STEP will focus on having improvements in self-efficacy through activities that boost value and self-esteem. Self-regulation and reinforcement will be used to help students manage their emotional triggers or seek support. Finally, positive reinforcement will be used to incentivize inquiring behavioral skills and practicing the coping mechanisms they learn. Now I'll pass it to Megan.
Thank you, Kendra. Now let's take a look at the logic model that is driving the STEP program. So our program relies on key inputs such as integrating the program within schools and then using experts and counselors to provide direct support and to build and maintain the reporting system. Teachers and peers will also help to implement the program, identify the bullying, and then support the students. And we're also working with community and faith-based groups and organizations to extend support beyond the schools. And with the use of these inputs, we want to focus on identifying target students through screening and collaborating with school leadership to deliver the interventions like the peer-based curriculums and the mindfulness methods. And within 3 to 6 months, we intend for increased awareness of bullying, better access to coping strategies, and improved communication among school leaders and communities. Within 6 months to a year, we intend for stronger student engagement with mental health services, more parental involvement, and better family cohesion. And within a year and ongoing, we intend for a reduction in bullying, improved mental health, and a lasting impact through the supportive policies and environments. And by following this model, we're confident we can make a more meaningful and lasting difference within Ghana. I will now hand it over to Yuande.
Thank you, Megan. So I'll be walking us through the evaluation plan. So our evaluation plan would comprise of the process evaluation, which is going to be an ongoing evaluation during the course of the program. We will be analyzing our online and in-person tools throughout the process. This would be a monthly and a quarterly evaluation. We would also be having focus group meetings and interviews with our participants as well as with the trainers to be able to see how effective these interventions are going, and also to be able to also measure the participants' engagement in these programs. At the end of the program, our program would also look at the outcome, would also evaluate the outcome. And we hope that at the end of the program, which is at the end of the school year, that there will be an increased knowledge about mental health and the effects of bullying amongst the participants. We also aim to see an improved willingness to the use of the mental health coping tools, which we would have introduced during the course of the program, increased willingness to support peers and to report bullying. And all of this will be measured with our pre and post survey using our DAS 21 questionnaire over time. And lastly, we aim to see a reduction in reported bullying incidents. We would measure this with by analyzing the school reports before the implementation of our program and at the end of the school year to measure the incidence of reporting as a whole. And also we would be implementing our OBVR questionnaire over time as well. Now I would hand it over to Noon. Thank you.
Thank you, Yuandis. Here I will discuss the STEP performance indicator that we believe when we measure it, it will give us an idea about our progress toward the desired outcome. So the first indicator will be the bullying reports, and that it will be achieved via tracking the incidents reported through the school's channels and STEP online platforms that we have designed. The second indicator will be the mental health indicator, where we will monitor the self-reported symptoms of stress, anxiety, and depression, as my colleague stated previously, using DSS questionnaire and making the comparison of pre and post. The third indicator will be the awareness. We will measure the student awareness about the bullying effect, hoping to achieve the desired percentage. The last indicator will be the comfortability of a student who feel safer to use our STEP coping tools. Now I will hand it over to my colleague, Yushenna.
Go ahead, Noon.
Okay, so in terms of our organizational capacity, STEP have a diverse.
Okay. I was muted, sorry.
Okay.
Continue. So what is our organizational capacity that ensures we are able to carry out this intervention program successfully? Our team has a combined 50 years experience in the following service areas: public health, psychology and behavioral science, childhood development, project management, data storytelling, and also we have clinicians and educators. We will be engaging and collaborating with stakeholders that have prior experience in childhood education and mental health treatment. We also will cooperate with equitable national and international agencies like Global Health Education Project, United Nations Children Education Fund, World Health Organization, and the TOLEC of Ghana, which is, they are well invested in school bullying intervention. We also engage local government agencies like the Ministry of Education and the Ministry of Health. We will liaise with relevant stakeholders, community stakeholders for easy community access, project promotion, and acceptability. To manage our resources, we intentionally have chosen 3 most developed areas in Ghana, in Accra, Kumasi, and Tema. This will help in easy project implementation, monitoring, evaluation within our budget of $120,000. Beyond the project intervention, our team will be mindful to empower schools. This includes being able to provide some basic educational materials and other resources to ensure they continue to progress and succeed in the post the intervention program. I'll now hand over to my colleague Noon.
Thank you, Yuchenna. STEP believed to have an important partner, whether globally or locally, to achieve our desired outcome. So we defined 3 types of partners. The first one is awareness partner in order to increase the knowledge about the bullying and our STEP intervention in the desired community. So we'll collaborate with UNICEF, UNESCO, church representative like Ghana Baptist Convention, and Muslim community initiative like Ghana Muslim Youth Association. The second type of partner will be the educational partner to make sure we are implementing the curricula in line with the educational protocol in the country. So we will collaborate with the Ministry of Education and local NGOs like Total Life Enhancement and Soft Life of Ghana, where they are already implementing their activities in the desired community. The last type of partner will be aiming to increase our political support around the bullying ramification and removing any barriers that it will appear in while we are implementing our mental health services in the outpatient clinic. So we will be partnering with Minister of Health and mental health authorities to provide the necessary support services to our program. Next slide, please. In terms of our program management staff, STEP have a different staff, diversing from director of operation who will manage and oversee the daily operation. We have the project director who will be managing any project related issues and allocate resources. We have our clinical and policy director who will be responsible for implementing anti-bullying policies and provide training and supervision to the group leaders. We have our director of outreach and community and communication, and who will organize the outreach events. Next slide. Also, we have our director of strategic partnership and who will be responsible for building relationship with the required partner in order to allocate the resources. We have our director of monitor and evaluation to ensure compliance with data collection and analysis. We have our director of technology and platform who will be responsible for managing and designing social media and promotional material. According to the nature of our intervention, STEP will recruit group leads to oversee the curriculum and manage student activities and providing the required mental health support to them. Also, we will recruit consultants to provide different expertise in yoga, IT, and psychology in order to support our program activities. Now I will hand it over to my colleague, Kendra.
Our dissemination has a twofold approach, both in-person and virtual. Pre-intervention, we will focus on a community outreach event, which will be pre-term 1. Additionally, we'll have partnership tabling events at our community partners like churches, hospitals, and schools. Virtually, we'll have Instagram blog style posts, which will be also in term 1, but also throughout the intervention based on in-person curriculum themes. During the intervention, we will have flyers and tools used during sessions like the theme stress balls and arts and craft materials that students can share with peers. Virtually, we'll have Instagram testimonials from consented students. Post-intervention, we'll have partnership tabling events to continue, but here we'll start to report our findings from the intervention. Virtually, we'll continue those Instagram testimonials, but also we'll post findings to increase engagement. So these can be polls, surveys, or any type of open format where we can have discussions. Next, I'll hand it to Megan.
Thank you, Kendra. I'll now walk you through some examples of our original promotional and educational materials. So these materials are designed to raise awareness about bullying and our program, as well as disseminate the valuable information. And the image in the center, that represents a potential social media post to educate the community on the coping mechanisms for bullying. And this can also serve as a resource for those who might benefit from additional support. The two other images are examples of flyers for our school events, and these templates can easily be adapted for other school systems and programs that also might want to aim to address bullying within their institutions. Next slide, please. Now let's review the budget for the STEP program. We allocated $56,000 for staffing, which covers salaries for the full-time and part-time staff, which includes all the directors that are running the program. We also allocated $11,000 to expert consultants such as counselors and IT specialists and our group leads, and these consultants will be contracted. We allocated $16,000 to cover travel expenses that is necessary for conducting outreach, training, and other essential activities that will be across the regions within Ghana. And we put $10,000 towards equipment and promotional material, which includes the cost of printing flyers, the curriculum, the themed coping tools such as the stress balls and the craft supplies. And for food, this came out to $15,000 for during the program events, meetings, and community outreach efforts. Lastly, we allocated $12,000 towards the fringe benefit, which was just 10% of our total budget amount. And altogether, these totaled $120,000, ensuring that we have the resources we need to effectively implement the STEP program and make a meaningful impact. I will now hand it off to Kendra, who will close this presentation for us.
Thank you, everyone, for your attention today. The STEP program is a vital initiative to combat bullying in Ghana and worldwide if we're able to expand. With your help, we can create safer environments for all students and help them cope with the tribulations of life in healthier ways. Together, we can make a real difference. Thank you again, and now we can open the floor for any questions.
Thank you so much. Group 3, we saved the best for the last. Look at you. Okay, so let us show them some love. Use the reaction button. What am I going to give them? I'm going to give them confetti. This is a big celebration. Congratulations, group number 3. And there is a lot of questions, Keep the questions coming. So I'm going to begin. So the first question we have here, and thank you so much, everyone, for sending your questions. Keep them coming. The first question is actually, you plan to use DAS and OBVQ survey. Are you going to translate those surveys into the local languages, or are you going to use the English version of these surveys? Who wants to take that?
We aim to use the English version of these surveys to stay consistent across all 3 cities.
Why is that? You don't think there is any relevance in translating? Is that because of the population? These are school children. What is the rationale?
The rationale is the location of our intervention program. That is Accra, Tema, and Kumasi are the 3 of the most developed area in Ghana. So it's basically English that is spoken by even the school children. So I think it's best that our assessment material be in English, because most of the students, the school children, speak and understand English because of the most of the schools are in urban areas. So that's one of the main reasons why we chose to leave it in English.
Okay.
And the official
yes,
language in Ghana is English. So just So we are focused on organization here, not necessarily all of the room location within Ghana.
Good. Okay. So the next question is, you will be implementing this program in schools and teachers are already starved with resources. How are you going to support teachers in these schools where you plan to implement STEP?
Our main resource for supporting all of the school administration is our help with our community partners. So we aim to really leverage the support of our community partners like TOLEC GC, who's already in the community within Ghana, to really aid in not only providing the physical support, but also the financial support. So I know our budget is 120,000, but with our community partners, we'll definitely be able to expand it to give more resources to teachers.
Are you going to give the funds to TOLEC, or are you expecting TOLEC to give funding support to the local partners? Can you explain?
Yes. So our group leads, teachers can actually sign on to be group leads to make additional funds. So anybody within the school administration who is a partner to the school or directly to the students can sign on. So individually, teachers can also get that additional pay, but in terms of financial resources, we're looking for them to support us so that we can support the teachers.
Good, good. So teachers who opt to become the leads can get financial resources. That's excellent. So somebody made a very important comment here. He said, is this a bullying program or an anti-bullying program? You know, what is in the name, right? What is in the name?
So Standing Together for Equity and Peace is meant to say against bullying. So it's an anti-bullying program because we are combating not only those who bully, but also those who are victims of bullying. So it's totally encompassing all the behaviors that can contribute to someone choosing to abuse someone or the impact of being someone who's abused.
So that's anti-bullying. Okay, many questions here. Another question here is, you said you talked about your study abroad program or abroad adventure abroad. How will you select this 10% of children who will participate? Are you going to turn children away from participating in this program?
No, not at all. So the Adventures Abroad, because it's paid for, the group leads will actually be able to give us feedback on who they think would be most beneficial to that program. The social and emotional skills from Friendly Schools and from Praise are very similar to what is in the Adventures Abroad, but if we find students who are not being taken in or being receptive to Friendly Schools of Praise, Adventures Abroad is a third tier to be able to try to get them.
So children will not be turned away, or they will be turned away?
They to be fair, they wouldn't even be aware of the program unless they would be part of the 10%.
Okay. Why did you select Instagram? You know, Instagram is not the only social media in Ghana. Why? What is your rationale for selecting Instagram as the primary method of communication?
So because we want to have engagement within groups for specifically under the age of 25, we chose Instagram because it tiers to a younger demographic. TikTok does as well, but you have to be much more visible within TikTok. And we are looking to share testimonials and engagement. And we need people to be anonymous to do that. We can't really do that with TikTok. Facebook is really geared towards an older generation and it just doesn't really fit our demographics.
I hear you, older generation. Okay. So somebody put in here, let me read that. It was not clear to me whether children who will participate in STEP will get any incentive. You know, here, I mean, if you anticipate that school kids will join a program, what are you going to give to them? Lunch, vouchers, or it wasn't clear to me. So this is what this person said. Can you address that?
Yes. So in the sessions, like part of our budget is food. So we do have snacks as part of the incentives to come before or after school to those sessions. Additionally, we will partner with schools to figure out what they consider or what's within their school handbook that is acceptable. We will provide like stress tools or arts and craft materials to incentivize them, and they can take that home as well. So That can be a stress ball with the STEP logo. That can be arts and craft tools. Like we have already budgeted for like sand, which is something that's really mechanical and really good for creating those traits that help to slow a child down in the middle of an aggressive stage.
Yeah,
so
I think
we
what
do
this
have
person is.
those kind of
I think
things that are part
what
of
this
STEP, but we
person
also, yeah.
what this person is pointing to is something tangible that these kids can take home, for their parents, just to incentivize them. Just wanted
So
to point that out.
that would be, like I said, our stress balls, our SAN activities that we plan to do within the classrooms. That is something they can take home.
Okay. So I have one question here, but I'm going to ask every group. So you can stop sharing, and then I think that question, I want each of the groups to answer that question. And if you guys can come on the camera, that would be very helpful. So one question here for group number 3 is that everybody here is a director who is going to implement the program.
What's the question?
Yes, the question was, everybody listed on the staffing on the team is a director, right?
Yes.
Project directors. Who are the people that would do the actual job? Group 3.
So the implementation really will be led by our group leads, as they are the ones who are controlling the sessions, and they'll really be providing feedback to us. So part of our process evaluation is to meet with the group leads and really get their feedback of what's going on in the classroom. So they are really key to the implementation process.
Thank you. Excellent. Group number 3. This is excellent. We're going to take a screenshot, but I have one question that cuts across all the 3 groups. I saved that. So for group number 1, let's begin with group number 1. How possible is it for you to implement this program in other counties in the United States? Remember, group 1 is ERI, right? Eat Right initiative to be implemented in Prince George's County in Maryland. We know Prince George's County is not the only place where you have food insecurity. How possible can this program be adapted for other counties in the United States? Group 1.
Thank you for that question, Dr. Romy. Yes, it can be implemented into other states. For example, I live here in Seattle, Washington, and food insecurity is also a primary problem here among children and families. So the program that we established, Eat Right Initiatives Vouchers, is kind of similar to the Seniors Farmers Market nutritional program vouchers given throughout several states in the United States. So it's something that is certainly doable.
Thank you. Group number 2. How possible is this program to be implemented in other African countries?
I think it is very possible to implement it because, as we know, diabetes is a world issue right now. And Africa in particular, there's a rise in diabetes in Africa. So we will just have to tailor it to the different country, the needs and the situation there. So it is very possible.
And group number 3, is it possible? How possible is it? Can you speak to your plan or your strategy to implement a STEP program beyond Ghana?
Yes. So STEP is a program that is aimed to be implemented wherever. So our program, as long as we have the financial backing and the physical backing, can be implemented wherever. The curricular that we have is from all over the world, not just the US based. So this is an innovative program that can be implemented wherever.
Yeah. If I may add, if we are talking like a country like Nigeria, which is far bigger than Ghana. So just like Kendra said, extra funding may be needed because we may have to do more than just 3 schools, because to have a good comparative analysis, we will do quite a number of schools, because of the population of Nigeria, which means more funding. But the program itself, the template for the program is workable anywhere in Africa.
Very good. Very good. That's very helpful. So adaptability and implementation. Yes, Noon, go ahead.
Okay, in addition to what my colleague said, STEP had an idea to implement this program in the future, even for the countries that are not talking in English. So for the Arabic countries, we had a plan to translate our promotional materials, to have a website that it will be designed in Arabic in order to capture the Arabic speak citizen, as this problem of bullying problem, it's well dispersed in most of the Arabic countries. So as my colleague said, STEP is flexible to be implemented in other countries, regardless even the language spoken by the community.
I can't wait to have STEP in MENA, Middle East and North Africa. I can't wait to have it. Okay, Saran.
Thank you, Dr. Rumi. As part of Kenya being eastern part of Africa, I really believe the program that we did can definitely be used here in Ethiopia. It might not be towards diabetes, but it could be related to cardiovascular health. And the major big thing that I noticed working with local NGO organizations here is that there aren't people that understand how to design a program. So the fact that we went through this 3 months program on how to design has really left me feeling confident. But I also understand the importance of funding, like somebody said today. But definitely it can be done here.
Good. We have another very important question about cultural sensitivity. So the question I'm going to read, are you worried, this is for group 3, are you worried about over incentivizing bullying and therefore weaponizing the same if you are giving rewards or gifts for victims of bullying?
Thank you. That's a good question. Oh, Shikoi, do you want to answer?
You can go ahead if you want to.
Okay. This is actually something we ended up adapting our program. Originally, the program was just going to be for people who were victims of bullying. We ended up adapting to those who were also perpetrators of bullying for this reason. We are not incentivizing bullying itself. We're incentivizing taking on STEP's coping tools and taking on and becoming a member of STEP. That's what the incentives are. So we are really aiming to have a whole child approach, and not just the victim, but also the perpetrators.
Yes, and just to add more about what Kendra was saying, we're not incentivizing them to join the program. What we're doing is providing them with tools to cope, whether with being bullied or having the stigma of bullying others. It all ties back into behavioral issues. If you're dealing with something cognitively or behavioral, we're going to give you tools to combat that, to eliminate stress, eliminate anxiety, eliminate depression, which all could either tailor your thoughts to harm or bully someone else, or eliminate the result of being bullied. We're not pretty much incentivizing them. Yes, we're providing them with tools such as yoga methods, breathing methods, stress balls, which you could use in strenuous situations, but we're not incentivizing them to actually join the program.
Good. So you are essentially presenting and addressing bullying as a public health program, right? As a holistic public health program. I think that's how you try to navigate these waters. And then another question, how will you take care of bullies to curb bullying?
So again, that's, oh, go ahead, Shannon.
Yes, research has shown that most of children that are bullies, have some problems, a background problem, either a family problem or a developmental problem, or a certain issue that they are struggling with. So the idea is also to bring them in and also counsel them. So find out the background challenges they have had that would have made them to become bullies, because some of them, bullying is a kind of protective mechanism to themselves, and you may not realize it. It's a way of making themselves feel strong because of what they have gone through. So it's very important that also these bullies are brought in and counseled and put through counseling. That will as well be done. Thank you.
So that raises another question for those of you, because you are now almost Africa experts, the two groups. How accessible are counselors in Africa and developing countries? For those of you that do have experience practicing in Africa, are there really resources, counseling resources for children who may be bullying perpetrators or who may be victims of bullying?
Honestly, there are counselors in most of the schools in Africa, but the question will be, are they trained enough to handle specific situations? So what we have are general counselors. They will just counsel you on everything and anything, which is not actually effective enough. There should be specifically trained counselors for a problem like this, bullying that leading to mental health issues in children. So that is it's a question of being trained enough. I don't think we have counselors that are trained up to standard, but we have counselors in most of the schools. But whether they are trained enough to handle specific issues in schools, I don't think so.
Thank you so much. I'm seeing a lot of kids joining us now. So kids are welcome. We are a family-friendly program. We are training the next generation of public health practitioners. So we hope they will listen in and they will love public health. All right. So we have actually wrapped up almost the program. I would like to again congratulate you, our summer cohort, for doing an excellent job. I know somebody texted me, what happens with these programs? And I thought that was a really good question. So if you are interested in partnering with any of these groups, reach out to GHCP. On our website, you will see our informational email, info@Global Health Projects. Then we will convene the group, and then we'll work with you to see if we can pilot these programs regardless of where the countries are. I really appreciate that question. We have one more question. What are the constitutional dictates for bullies in Ghana? How will you navigate bringing bullies identified from STEP to justice? Good question. No, you are doing the program, and you identify individuals as bullies. Will you report them or will you not report them? How do you, it's both ethical as well as legal, right? Kendra and team, do you want to take that question?
Yes. So firstly, we don't identify people as bullies. That we would not label them that way. Part of the program is to empower students to be able to report bullying themselves. A strong part of the program is to work with the school administrations to update their handbooks to reflect anti-bullying policies. We can't tell the school what to do or how to handle bullies. That is up to the school administration, but we will work with community partners who are great at developing policies to make sure that it is fair in terms of providing some type of repercussions. But we do not we won't provide those kind of repercussions for bullying.
Good. And there is another one, right? Another observation. I think that your awareness creation tools should include information for parents in the community. I think it does. And then this will help to avoid raising future bullying perpetrators. Excellent, excellent advice. Excellent advice. Okay, so I want to open the floor now to any, at least maybe one person each group just to share concluding remarks. It's not a valedictory speech, just something to share your experience over the last 3 months of being in this program. We can just have one person per group. It doesn't matter who the person is. If you are so-called, just to share one comment, one feedback over the journey in the last 3 months, and then we can wrap up the program. We can start anyway. It doesn't matter. Group 3, group 2, group 1. I know Chakoya will like that. It doesn't matter which group. We're not going to do 1, 2, 3. Any group.
I would just like to say, for representing Group 2, this has been a very rewarding experience. I think collectively for us, Dr. Romy and your staff has been very supportive and bringing the ideas to us, educating us, training us in how to design and develop public health programs. But we feel really confident in speaking about them, researching them, presenting them, and hopefully pitching them to someone that may be interested in bringing it to their country. So on a personal note, the outreach and the capstone were programs for me that was a stretch, but I feel like I rose to the occasion. And these are valuable partnerships that I have with my students and fellows and just community at large. So I just want my comment to be more of a appreciative thank you for everyone.
Thank you, Dr. Judd Burns. That was really great. Okay, who else? I'm looking at faces.
Okay, I can go for speak behalf of Group 1. I think just like I would just add to what Tanya said. It was really fulfilling, this whole journey with PH360. It's more than that I expected in terms of building confidence and designing programs that is really meaningful. These are pressing issues we worked on, and it was really satisfying and gives you that energy to look into things, research it very well, and write up proposals. All those elements included in writing the proposals where so much hard work went into it. It pushed us to all our limits to get the right information to put together. And I want to thank all of the PH360 staff for the support. And you guys were so prompt to respond to our questions and requests. So I'm so grateful I did this program.
Thank you so much, Leah. That's excellent feedback. You didn't want to reveal that the program is really that tough. Dr. Rami is not nice, right? Behind the curtain, he's really not a nice person. But, maybe you're trying to hold that back until people enter the program. All right, one more comment, one more feedback. General remarks.
I guess I can go for my group. So I would say that the experience was very validating. And I'll say that because we talked about imposter syndrome a lot, and I think many of us can succumb to that. And this program, especially since it's so small, allowed many of us to tap into skills that we didn't necessarily know that we had. And learning is an iterative process. So it definitely allowed us to develop in this short 3 months, a very, very short 3 months. But definitely the teamwork and the network that we've created here, I think will be long lasting, and hopefully we can continue to connect in the future.
Thank you. Thank you. Yeah, thank you. This is, if you don't feel the discomfort then this program has not worked for you. I think that's what I tell people. How do you know this program has worked for you? Is when you feel the discomfort, when you begin to battle with that imposter syndrome. Can I or can I not do it? Right? If you don't get to that point, then the program has not transformed you. So Kendra, you're really right. It has to take you away. Remember, each of you know more than you are willing to accept. And that is where that imposter syndrome kicks in. You know more than these programs. Like I said, these 3 challenges, nobody knew the answer. It's not like we have the answer and then we're asking you to do that. You are creating, we're encountering the problems as you were just encountering them. And these programs are brand new programs, never exist anywhere. So it's not easy, but it is rewarding. Yes, Blessing, Dr. Blessing, she cooked for us in the community outreach. I can't wait to have that food. Whenever we have a live conference, it's in Washington, it's in Canada, it's in London, you're going to cook for us. You muted yourself.
Yeah, thank you so much. This is a great privilege to actually be a part of this program. I want to really appreciate Dr. Chidubem. He actually introduced me to this forum, and I don't have regrets. It actually pushed me because I had so much on my plate this period. It was like I was almost going mental at a point, but at least at the end, it turned out very well because it gave me an edge in a lot of places. We had a conference recently, and with what I learned from this program, I was able to stand out in that conference. And they were like, "Are you running any public health program?" And it was obvious that I was way ahead of them in the public health issues and discussion. I want to appreciate you, Dr. Romy, and all the faculty. You guys are doing a wonderful job. Well done. We appreciate you. And definitely one day we'll all meet in person and we'll be meeting on top. Thank you so much, sir.
Thank you. That's my aspiration, that we all can meet ourselves somewhere in person, for this global meet. Stand by. All right. So, Brown, I'm going to hand over to you for concluding remarks, but I am so proud of you. Keep those letter of recommendation requests coming. We love them, right? You know how to reach me. You know how to reach Dr. Nzube. We do really love personal recommendations. 50% of people who join this program join them because someone told them about the program. I know people tell us we are not marketing the program that much. The reason is because once we market, then we lose the personal relationship that we have with our students. That's really something that we think that this intervention needs. We don't want to be a university that yet, because when we become a university, then we are not going to be accountable for everybody. But you are here because you cut the mark and you are living here better social change agents. We believe in you, and we believe in you that you are going to always keep health disparities front and center of your career. Go change the world. Congratulations from all of us, all the faculty. I cannot say that enough. They have been instrumental in making this really, really run. Dr. Susan Brown, Dr. Chidubem, Dr. Nzube, all of them, for supporting you. We are so proud. Remember, you are still part of this community all your career. You are always going to be welcome. We'll reach out to you to invite you to participate in programs. We invite you. You're going to be our reviewers for our journals. So once a PH360 fellow, always a PH360 fellow. Congratulations. Brown, any last minute announcements?
Yes, Dr. Romy, I am excited to see what you all have become, the program that you've developed. I remember the first section. When you look back, it was kind of, so where are we going? This is that day that I told you that you look back and you appreciate how it's all went, what you've achieved, what you've become, ethically, know about the organization, know how to create a program. if your manager walks in program and say, well, we're going here, design a program that will do this, or design an awareness program, you can do it. That go to the world and be an advocate of public health and keep improving, at least for us, which our dream is to ensure that diverse views, that people that could speak up for us are there. You all are representative of that diverse view that will go ahead and implement social change that will prevent ill health, that will make us healthy. Prevention is better than cure. And for those clinicians who are here that is having a touch of public health, you will be able to, see it at a community level and prevent ill health at that stage. Thank you so much. And we'll have the next cohort, 4 cohorts, will be beginning next week. Apply and see if you could be part. It's almost filled. We always give preference to people coming from developing countries. Once we get more of people from developed, we always want people from developing countries. So it could be have that touch of international touch where you will learn from people in developed, and people from developing countries will also have the opportunity to learn from you. Thank you so much. Word of mouth is the best. Keep, be the mouthpiece, be the advertiser of this program. We've shared the link. Feel free to, this live section is there. Feel free to point back to it. Thank you so much. So I'll be ending, and I will be celebrating with this nice music. Thank you so much. Thank you so much, everyone that joined. And we'll be ending the meeting here, and keep passing on the love. Thank you so much, everyone that joined, from our past participants, all the people you invited, people from Nigeria, people who saw the flyer. Keep spreading the word. It was a nice one today.
Congratulations to our future public health kings and queens, right? All right. Bye-bye.